Okay, ladies and gentlemen, our first speaker for the SARSA Virtual Summit is a true luminary in the field of gastroenterology. With a passion for improving the lives of those affected by inflammatory bowel disease, Dr. David Epstein is a beacon of knowledge and compassion. Dr. Epstein's journey in medicine began at the University of Cape Town, where he laid the foundation for a remarkable career dedicated to healing and understanding. His impressive academic journey led to the acquisition of several prestigious qualifications. But it's not just his academic achievements that set him apart. Dr. Epstein has been on a lifelong mission to make a difference. He founded the nonprofit organization IBD Africa in 2019 with a vision to enhance the lives of individuals living with IBD in sub-Saharan Africa through research, education, and advocacy. Part of this noble initiative is the IBD Africa Registry, a pivotal resource for understanding and managing IBD in the region. Today, Dr. Epstein will share his extensive insights on inflammatory bowel disease, a condition that affects countless lives. His dedication to IBD care extends to a multidisciplinary practice where he provides treatment for children, adolescents, and adults. As we eagerly await Dr. Epstein's wisdom, let's remember that it's through individuals like him that we make progress, transform lives, and shape a better future for all of those impacted with IBD. Please join me in giving a warm welcome to Dr. David Epstein.
Thank you, Matthew, and to Miranda for inviting me, and thanks for that very generous introduction. I just want to check that you can see my screen.
We have got it. Perfect.
You can see everything.
Perfect. Thank you.
Good. Right. So yeah, thanks everyone, and yeah, I'm very pleased and privileged to talk to you today about AxSpA and its relationship to inflammatory bowel disease. This talk, will cover a number of aspects of both IBD and AxSpA and where these two conditions overlap, and then just some of the information that I've given to patients with inflammatory bowel disease, which I think is as relevant to patients with AxSpA. All right, so before I talk, I'll just tell you about the organ that I'm interested in and that I work in. It's called the gastrointestinal tract, or the gut, and it extends from the mouth all the way to the anus, and it's about 9 meters in length. And fortunately, it's packaged very neatly under our diaphragm. If it wasn't, it would be quite a long thing to drag along behind us. So just some facts and trivia. It's 9 meters long. And as I said, it consists of various components. The gut surface area is about the size of a tennis court. So if you had to spread out the entire gut flat, that's a very large surface area. At birth, our guts are colonized by bacteria, usually from our mother. But in the first 3 years of life, we have an established gut microbiome. These are the bacteria that and other organisms that live inside our guts. And our gut is home to 100 trillion different types of fungi, bacteria, and viruses. So we have this huge burden of bugs living in our gut. Interestingly, 90% of serotonin is an important neurotransmitter and plays an important role in mood and anxiety. 90% of that is produced in the gut. And 70% of our immune system, in fact, is in the gut. So because of this large surface area, it has to be protected. And I think the gut health is something that's captured the public imagination, and there's a multi-billion-dollar gut health industry, which I'm sure all of you have encountered in one form or another. So I'm going to start my talk with this story about a polar bear called Nut, who was born in captivity in the Berlin Zoo in 2007. And this polar bear was abandoned by its mother at birth, and it was nursed in an incubator, a normal sort of incubator that we'd use for babies, for the first 44 days of its life. And then it was placed into its own enclosure. It was fed baby formula, and then it was weaned to tinned cat food, and then it received some antibiotics for a teething problem. And then suddenly at the age of 4, it died. And it was thought that the polar bear died from encephalitis, an infection of the brain. And this article caught my attention a couple of years ago in the Cape Argus. And in fact, this polar bear died from an autoimmune condition, a type of autoimmune encephalitis. And there's a message in this story which I'm going to return to later in my presentation. So autoimmune diseases are common. Basically, if we had to describe an autoimmune disease, it's a failure of tolerance to self. So we don't tolerate something that belongs to us. It was first described in 1901 as a condition, but the first autoimmune disease was really described accurately in 1938, and some of them are very common, some of them are rare, but they share a number of similarities. It's estimated there are over 100 autoimmune diseases. 50 million Americans are afflicted by autoimmune disease, and 25% of people with an autoimmune disease will have one or more autoimmune disease. So they tend to cluster, and that's also going to be relevant in the talk. So what is inflammatory bowel disease? It's a disease of modern living. It's a type of autoimmune disease, and it causes inflammation and ulceration in the gut. And when we talk about inflammation, we talk about redness and swelling. So I've given you the example of someone with a pimple or boil on their arm causing inflammation around that area. So that's what we mean when we talk about inflammation. And ulceration is when the lining of a surface is eroded. And all of us have at some time or another had a mouth ulcer. So that's what we mean when we talk about ulceration. IBD comes in 2 varieties, Crohn's disease and ulcerative colitis. And it is associated with what we call extraintestinal manifestations. These are often immune-mediated manifestations that occur outside the gut. So peripheral arthritis and axSpA are well-known extraintestinal manifestations of IBD. So when we talk about ulcerative colitis, it's a condition that only affects the colon, and it affects the colon to varying degrees. So some patient might just have a small amount, like in the rectum, or more extensive involvement, or the whole colon can be involved. And as I said, the disease will cause ulceration and inflammation. Crohn's disease, it's got the name after one of the first doctors to describe the condition, Dr. Beryl Crohn. And Crohn's differs from ulcerative colitis in that it can affect any part of the gut. So it doesn't only affect the colon like ulcerative colitis, but any part of the gut. It often has this tendency to affect the terminal ileum, which is the last part of the small intestine where it joins the colon. And that's that picture in the bottom right of your screen. And the other thing about Crohn's disease, which really adds to the debility of this condition, is that it has this tendency to burrow or penetrate through the gut lining, causing things such as fistulas and abscesses. And these are some of the most sort of devastating complications of this disease. So what are the symptoms of IBD? They're slightly different between Crohn's and ulcerative colitis, but common symptoms include diarrhea with blood or mucus in the stool. In ulcerative colitis, patients often have the sense of urgency, needing to pass a stool very quickly. They might not make it to the toilet in time and suffer with incontinence. There's stomach cramps, and in severe cases, there'll be weight loss and fatigue. Crohn's disease similarly has stomach cramps, may have diarrhea, sometimes constipation, loss of weight and fatigue, and then this tendency to cause fistulas and abscesses. Right. So what causes inflammatory bowel disease? We recognize 4 areas. First is genetics, and there's about 20% of patients with IBD will have a family member who has the disease. It's also very important that the disease seems to be related to the types of bacteria that are living in our intestines and colons, and I'll come back to that later. Certainly a number of environmental triggers, and those can be past, present, or future environmental triggers. We'll come back to that. And then our immune response, how our gut immune system responds to harmless bacteria. And people with IBD will have slightly subtle differences in the immune system, which renders them susceptible. So I'm going to just look at this under the microscope. So what we have at the top of the picture is all the digested food and bacteria that live in our colons. We then have a very thin layer of mucus. Then we've got a single layer of cells that provides the gut lining, so extremely thin. And then just below that is our immune system. Now you can see that having a large burden of bacteria so close to our immune system, which is designed to protect us, is potentially dangerous because the immune system tends to react to bacteria, but our bodies, well, our immune systems tolerate this burden. They recognize that these bacteria are harmless, they're important for our health. So the immune system tolerates this large amount of bacteria. But if, for example, we get gastroenteritis or cholera or salmonella, then our immune system will recognize that those bacteria are dangerous and will go on the attack to protect us. So under normal circumstances, there's this harmonious relationship between harmless bacteria and our immune system. And when we do our scope tests, where we look into the gut, we see these very beautiful pictures of what it looks like if you've got a healthy colon and intestine. Right, but if you get inflammatory bowel disease, for some reason you lose tolerance to these very harmless bacteria, and so the immune system goes on the attack and our gut becomes the battlefield. And there's this ongoing battle between harmless bacteria and an immune system that recognizes these bacteria as dangerous. And then we have this inflammation and ulceration, which causes extreme damage to the gut. And these are some of the more extreme pictures that we see when patients have inflammatory bowel disease. So Matthew mentioned some of the research work that we do. And this is just some data from our registry showing that over the last 50 to 60 years, there's been a steady increase in the number of patients diagnosed with IBD in Cape Town every year. And if you look at the increase in IBD around the world, one can see that in newly industrialized countries, it almost mirrors exactly what we're experiencing in South Africa. From the mid-1950s, a steady increase in new cases of IBD around the world. And that will also become more relevant when in later slides. Something slightly different between IBD and AxSpA is that most of our patients are diagnosed at a very young age. And I think the average age of diagnosis in AxSpA is more in the 40s. We see adolescents and young adults as our most common age group where people are diagnosed, and we have patients as young as 2-3 years old. But the vast majority of our patients are in their late teens, early 20s. And this is when people are at their most productive, starting their careers, studying at university, wanting to travel, wanting to start families. And so this disease has a huge impact on all those aspects of their life. So just understanding some of the origins of IBD, we know that as infectious, and this is a slide I showed to doctors, but I've put it up here just for interest, that as infectious diseases such as hepatitis A and tuberculosis and rheumatic fever have decreased over the last 100 years, so there's been an increase in autoimmune diseases like multiple sclerosis, Crohn's disease, asthma. So there seems to be this difference of a diminishing number of infectious disease and at the same time an increasing number of autoimmune disease. We know that in IBD, there have been a number of environmental factors that have been associated with the onset of IBD or play a role in the development of IBD, such as diet, stress, smoking, pollution, migration, whether you were breastfed or not, whether you got antibiotics in your first year of life. So all these things, many of them related to modern living, seem to play an important role in IBD. And this at the bottom left is a very interesting article that I came across. And this was a study in Italy where they examined breast milk in moms who'd recently given birth. And 26 out of 34 breast milk samples contained evidence of microplastics. Now, we know microplastics is a huge problem. They contaminate the environment, and one can only imagine what the small plastic particles would do to the gut of a newborn baby and how it would affect the immune system and cause all sorts of changes that are not part of a normal exposure to a newborn. So this shows you the sort of interface or the link between modern living and these diseases that we are seeing in increasing numbers. All right, so just more about modern living and IBD. I think one of the biggest changes that happen when countries industrialize is that their diet changes and they move from a more traditional diet to the one that we're all familiar with and associated with developed countries, fast foods, highly refined carbohydrates, etc. And on the right, I just looked at the FDA website to see what additives are approved for use in food in America. And I got to the A's and I stopped at that point because the list just was exhaustive. So this just shows you all the things in modern food that surely must be having some effect on our guts and our immune systems. And this brings us back to the story of the polar bear, whose upbringing was very different to one that one would expect from your average polar bear in a probably very dirty, contaminated environment, no antibiotics, no tinned cat food, no bottle fed, no antibiotics. So again, a sort of polar bear thrust into a very modern, clean environment and ended up with an autoimmune disease. All right, so just when we talk about extraintestinal manifestations of IBD, up to 40% of IBD patients will have one or more manifestation outside the gut. And this may occur before the onset of IBD, or it may occur after the onset of IBD. It tends to be more common in patients with Crohn's disease than ulcerative colitis. And what's interesting is that some of these extraintestinal manifestations can flare up when the IBD flares up. So a patient who's having a flare of their ulcerative colitis might experience a painful knee or swollen ankle at the same time. But then there are other extraintestinal manifestations such as axSpA, which may follow a course independent of the IBD. So the IBD may be in complete remission and the axSpA may continue to be a problem and to be progressive. So some of them follow an independent course and some of them flare in tandem with IBD. We do notice that certain patients with IBD might have a predilection for certain extraintestinal manifestations, which I've mentioned there. So these are just some of the things we see, and there's numerous sort of manifestations. These are some we've seen in our practice, but it's a lot of skin, gut, and joint. Those are the most common areas that tend to get affected in patients with inflammatory bowel disease, but there's a wide range of extraintestinal manifestations. But skin, gut, and skin, joint, and eyes, are the most common extraintestinal manifestations that we tend to see. Now, what is the relationship between axSpA, the joints, and the gut? And this is a very fascinating area. I don't think we have all the answers. But firstly, we know that there's a condition called reactive arthritis. It's a type of autoimmune arthritis that develops after an infection. And usually that infection is a gut infection. So something that happens in the gut can somehow trigger an autoimmune arthritis. We also know that if you take all axSpA patients and look for very subtle signs of inflammation in their gut, up to 46% will show that they do have subtle inflammation. It doesn't mean they have any symptoms. It doesn't mean they need any particular treatment, but it's just something that researchers have identified. We also know, and this is also very interesting research, showing that there may be differences in the gut microbiome or the bugs that live in our gut in terms of their diversity and composition in patients with axSpA compared to people who don't have axSpA. So maybe like IBD, axSpA may be associated with a certain lack of gut diversity and a certain difference in the percentages of types of bacteria that are present. And it's interesting that half of all axSpA patients will have gut symptoms. It doesn't necessarily mean that they've got IBD, but there is it's a common symptom in patients with axSpA. So this is really just an interesting slide. We don't have all the answers. We're not suggesting that people with axSpA should have stool transplants and try and change their gut bacteria, but these are just some of the interesting research that is available at present, and I'm sure there's going to be a lot more of this in the future. So I'm going to just give you some goals of IBD treatment because I think they do overlap with axSpA treatment. So these are some of the things we focus on when we treat our patients. We don't only want our patients to feel better, although that's their priority. They want to feel better, but we want what we call complete remission, where there's complete healing of the gut. When we do a scope test and we look inside, it looks completely normal. If we have achieved that, then we've really hit the target. I think we also have to keep a vigilance for extraintestinal manifestations. A lot of gastroenterologists tend to focus on gut symptoms when they see their patients. Not many will ask, Do you have any backache? What do you feel like in the morning? Is there any stiffness? And it's important for us to just keep vigilant, because these extraintestinal manifestations can creep up quite subtly and go under the radar. And as I've learned, the delay in diagnosis is really prolonged in patients with axSpA. So very important that we just keep a vigilance, ask patients about joints, their back, their eyes, their skin. For our patients, we want to avoid gut surgery. That's not good for patients. We don't want to cause any harm with our drugs. We want them to have a normal quality of life, and we aim for holistic remission, all aspects of their life: physical, mental, emotional well-being. And then because we see a lot of young children with IBD, we have to successfully transition them from a child based care to adult-based care, which comes with all its challenges. These are a slide I often show my patients. When you're having a flare of IBD, you pretty much know all about it. But a lot of patients have what's called smoldering IBD, where they might feel fine, but there's a slow burn of inflammation in the gut, and that does cause damage. And then we aim for complete remission. The fire is completely extinguished, and a patient experiences good health. I also tell my patients that IBD is not a individual sport; it's a team sport. It's impossible to manage IBD patients without a good support team, and included in that is a rheumatologist who can be called upon when we have difficulty with joint symptoms and not sure what the cause may be. But we have a wide range of specialists who help us. Right. So how do we approach the patient with axSpA who's got stomach symptoms? And I've just identified 4 things that I think of when I see patients. The first thing is medication. So we know that a lot of patients with axSpA are using medications that can affect their gut, and I've mentioned some of them there. Then we always worry, is this patient developing inflammatory bowel disease? Is this another autoimmune gut problem, or is this IBS? And I'll explain why we think of those 4 things when someone has stomach symptoms. So just to talk about drugs, so non-steroidal anti-inflammatories, I'm sure you're all familiar with them, and they are definite necessary evil. They probably provide people with fantastic symptom relief, but they are toxic to the gut. They affect the stomach, the small intestine, the colon, and the liver. Some of them might be safer than others. So our COX-2 inhibitors, such as our Arcoxia or Celebrex, may be safer than your what we call non-selective non-steroidals like Brufen and Voltaren. I think it's important to use them as prescribed and avoid duplication. You often see people, prescribed one anti-inflammatory, but buying over-the-counter Brufen to add to that, and someone else giving them another tablet to use. And we often see people on 2 or 3 anti-inflammatories, and the toxicity increases the more you take. But they do cause stomach issues. Steroids, which might be an important treatment option, also can affect the stomach, particularly giving stomach issues, gastritis, and ulcers. And then cilazapirine, which is a drug that some of you may be familiar with. I think its most common side effect is nausea. The enteric-coated version may be better. And then any drug that affects the immune system can render you susceptible to a gut infection. And, the anti-TNFs are an important treatment in axSpA. And so one has to be aware that a patient on an immune suppressing drug may have picked up a gut infection, and that may explain their symptoms. And rarely there's a biologic drug called Cosentyx, which some of you may be familiar with, but this biologic, interestingly, can actually increase the risk of developing IBD. It has a sort of what we call a paradoxical effect. So although it treats axSpA, it may actually render someone susceptible to IBD, but that's very rare, and it's not something I've encountered very often. Just to talk about the autoimmune diseases that affect the gut and IBS. So when we see someone with axSpA who has gut symptoms, we think about Crohn's disease, ulcerative colitis. Then there are 2 other autoimmune gut conditions that we keep in mind. The one is celiac disease. It's a gluten-related autoimmune disease, and microscopic colitis is another autoimmune disease of the colon. And I mention IBS because IBS is not related to axSpA. It's not an extraintestinal manifestation of IBD. So it's got nothing to do with autoimmune disease, but it is a very common gut problem. And almost 1 in 5 people will have experienced IBS at one stage in their life. So people with axSpA quite possibly have IBS as the cause for their stomach problem. It's got nothing to do with autoimmune disease. It's just a very common condition. So it's not autoimmune. It presents with bloating and pain and constipation or diarrhea. It's not due to inflammation. It's more due to increased gut sensitivity. You could say it's a condition that affects the gut nervous system. Right. So what do we do when we encounter someone with gut symptoms who has AxSpA? I think the first thing is we do like to do some blood tests to look at inflammation levels. And a lot of the tests we use to measure inflammation are the same that are used in AxSpA. These are blood tests such as ESR or CRP, just to tell us, is there inflammation present? And then if there is it coming from the back or is it coming from the gut? Anemia is a common problem in patients with inflammatory bowel disease and low iron levels. So we'll always check that in patients with gut symptoms. And if we see anemia and low iron levels, our suspicion of inflammatory bowel disease increases. Then some very simple tests that are useful is the one we use in our patients is called a calprotectin test. It's a stool test, and it's a very accurate measurement of gut inflammation. And that will help us, decide whether we need to actually move forward with other tests if we see that there's a high calprotectin level in the stool. We can also check for infections. And then we can do some non-invasive tests like scans of the abdomen, and very similar to what AxSpA patients may be familiar with, MRI scans, CT scans. But probably a very important part of our work is to do a gastroscopy and colonoscopy. These are invasive tests where we pass a camera into the gut from the top and the bottom. We can take biopsies, we can look for abnormalities. And then based on these 4 tests, we should be able to give every AxSpA patient an answer and a treatment plan. So I think very commonly we might see problems related to medication, and then we have to think of adjusting those medications. How can we use these medications more effectively? Can we stop certain medications? If a patient's relying on nonsteroidals, but it's causing stomach problems, then maybe we have to consider escalating their treatment to another treatment modality that will allow them to manage without a nonsteroidal. So these are all the things that, the decisions that we have to make, often in conjunction with a rheumatologist. So if it's a medication-related issue, we really have to look at making adjustments. If we find that the patient has inflammatory bowel disease, then we definitely need to work with a rheumatologist to say, right, how can we combine our treatments for the patient's best outcome? Because some drugs are very good for IBD, but not for AxSpA. Some drugs might be very good for AxSpA, but not for IBD. So it takes a team effort to try and work on a treatment strategy that's going to suit both conditions. If we find other autoimmune gut problems, so celiac disease is a gluten-related illness, its treatment is a gluten-free diet. Microscopic colitis, we use a particular type of steroid that works only in the gut, and that works pretty well. And then IBS, which is a very common situation, really is more lifestyle with diet, natural remedies, using something to reduce gut sensitivity, addressing anxiety and depression if that's part of someone's IBS. So that's pretty much the approach we would take to someone who has AxSpA and stomach symptoms. Right. I'm just going to talk a little bit about biological therapy, and this is something that I spoke to our patients about, and I think it might have relevance to people with AxSpA. So, I sort of view the immune system in 2 ways. The one is it's an orchestra. It's a highly complicated system. We probably don't even understand it adequately, but the immune system really functions like an orchestra. And if you've got an immune-mediated disease or a disease due to an overactive immune system, you have 2 approaches. You can either use the shotgun approach and blast the entire orchestra, which is drugs such as steroids that just have a broad immune suppressant effect, or you can go with a sniper and decide, okay, I'm going to take out the violin players only. And your orchestra will continue to function, but hopefully by just taking out the violin players, you will control the immune-mediated disease. The other thing about the immune system is it's like a river delta, and if you block one tributary, often with time, the immune system will find another way to the sea. And that is a a thing we noticed in treating autoimmune diseases is that we may have a treatment that works successfully for some time, and then suddenly it stops working, and people have a loss of response to their treatment. And that's because the immune system seems to have rerouted itself. So just a little bit about the biologic drugs. So if you look at the complexity of the molecules, this is a prednisone molecule, which is very small. By comparison, infliximab, which is a drug commonly used in axSpA, is a highly complicated molecule by comparison. So I compare this to a bicycle and a large aeroplane. Very simple to assemble a bicycle. A different story when it comes to building an airplane. And that's why your prednisone, are probably one of the cheapest drugs on the market. You can, they really are. You pay literally a few rands for prednisone, but you would pay a lot more for a biological drug. But then at the same time, we know that the prednisone will wipe out your entire orchestra, take out the conductor and a couple of the players, whereas our monoclonal antibodies, such as infliximab, are more targeted. They will just take out the violin players, and they're designed to do that. So you can see the differences in these types of medication. So just some of the drugs that we use for IBD and when they were launched. So we have the anti-TNF drugs, which I'm sure you're familiar with, which are used for axSpA. But then we have others such as vedolizumab, which is a gut-specific biologic. It only works in the gut. So this is not a great drug to use if someone has both axSpA and IBD. It's not going to help the axSpA at all. And then we've got something called ustekinumab. I think in axSpA, etanercept is a drug we don't use, but it's useful in axSpA. So, for example, a patient who develops IBD and is on etanercept might be better off switching to another anti-TNF such as Revilex, which then will treat both conditions. So this is how we can customize treatment so that both conditions are covered. Just some things about the biologics. They come in different formulations. You can get them intravenously or as a subcutaneous injection. As I mentioned, they target components of the immune system. Some are gut specific, some treat gut and extraintestinal manifestations. We generally treat through pregnancy. So many of our younger patients, are starting families. So we continue with treatment through pregnancy. One can check the levels of biologic drugs in the blood and optimize the therapy and the dosing according to those levels. I've mentioned this thing about loss of response, which I'm sure is something that does happen with axSpA, and I've used the river delta analogy there. And then there is this thing of diminishing returns. We find in IBD that every time you move to a second biologic, it maybe never works quite as well as the first. And when you start your third biologic, the chances of it working are even less. So this concept of diminishing returns every time you use a new biologic drug. And then we are seeing a number of biosimilars coming onto the market, which has resulted in a huge reduction in the price, but not necessarily the availability to all patients, unfortunately. Just some future in terms of biologics. As I mentioned, price reductions are coming down, ease of use, so from intravenous to self-administered. And then we're seeing these new drugs called dual biologics, where you might have two components to the biologic drug attacking different components of the immune system. And that obviously will result in more effective therapies. And that's a very exciting development. I'm just going to talk briefly about small molecules. We're using them in IBD, and I think they are emerging as a treatment for axSpA. These are the size of normal medications, so they're not biologics. They do attack the immune system or suppress the immune system in a way more aligned with biologics than regular treatments. They are tablets. They work very quickly, and they're not prone to many of the limitations of biologics. And the two that are on the market in South Africa at the moment are what we call JAK inhibitors or Janus kinase inhibitors. And there are two products that are on the market that have really added just another option for our patients and may be relevant to patients with axSpA. They do come with side effects, and obviously one has to be careful about that, but it just gives us another alternative to a biologic if we need one. All right, so if one has to look at the road to a sustained remission for IBD or axSpA or any of the immune-mediated inflammatory conditions. We have a whole range of these things now. And how do we decide where to start? What's the best drug for the best patient? And unfortunately, at the moment, we do sort of rely on guidelines, which is just a gathering of all the evidence, all the research, and saying, well, based on all the research, it seems that starting with this drug for this condition at this time is correct. And if that doesn't work, go to this drug. And if that doesn't work, go to that drug. But it really is a trial and error. We don't know which patients, for example, with AXPAR should not even start non-steroidals, because go straight away to a JAK inhibitor or to a biologic drug. We don't know. It's just which patient is going to do very well just on an anti-inflammatory. We can't always predict that. And it's the same in IBD. We've got a range of these drugs. Which one is going to be the best one to start with? We don't want to expose patients who have a very mild disease to a toxic drug when their disease is never really going to have much impact on them. And then we certainly don't want to treat a patient who's going to have a very severe course down the line with a drug that's not going to really be a good match for them. And we're really moving into this thing of precision medicine. And this is where we might do a blood test or a stool test or a biopsy from the colon, and based on that, have a targeted therapy, choosing the drug that's going to be the best fit for that patient. And that's really where treatment for immune-mediated disease is heading. So rather than relying on guidelines and past experiences and slight trial and error approach, we're going to have more targeted therapy in future. And I'm sure that will apply to patients with AXPAR as well. All right, just a little bit about the organization that I'm involved in. It's called IBD Africa, and Matthew mentioned some of the work we do. But interestingly, I met Miranda at our IBD Africa Advocacy Project, and this was a workshop that we ran last year for training patients in advocacy. And we were hoping to just have IBD patients and providing a workshop just for IBD patients. But our sponsors, who were a pharmaceutical company who treated a lot of autoimmune diseases, said no, that if in terms of the sponsorship agreement, we had to include patients with other autoimmune diseases. So very reluctantly, we had to invite other people. So there were people with AXPAR and rheumatoid arthritis and some skin conditions. And in fact, that was the best thing that ever happened to us, because we really got to share experiences and knowledge amongst different autoimmune diseases. We understood the other diseases better. We learned about new approaches to advocacy and patient organizations. And we realized that we had very similar challenges: delayed diagnosis, difficult access to therapy, failure of medical schemes to comply with the Healthcare Act. And following that meeting, we decided to form an organization called the Autoimmune Alliance of South Africa, where we bring patients of a variety of autoimmune diseases under one umbrella to increase our voice, so that when it comes to negotiating for benefits and adequate care, we're talking with a much louder voice, much greater leverage, and hopefully much more success with our advocacy initiatives. And we launched this organization with an article in Daily Maverick earlier this year. And, I'm not going to go into this, but one of our challenges as the Autoimmune Alliance is to, tackle this whole issue of PMB conditions and PMB care, which is really a stumbling block to adequate care for so many patients with immune-mediated illnesses, and is a completely fabricated or artificial construct. It bears no relationship to reality. Why one person with an autoimmune disease gets their condition is a PMB condition and they can access care, and someone with another autoimmune condition who suffers just as much disability and morbidity because they happen to have a certain ICD code attached to their disease, don't get access to care. And that's a completely artificial construct. And so we really are making good progress in trying to level the playing fields and making sure that all patients with autoimmune diseases get access to care. So in conclusion, I've talked about autoimmune diseases. They're increasing and related to modern living. Extraintestinal manifestations, including AXPAR, can occur before or after the onset of IBD. half of AxSpA patients suffer with gut symptoms. We have to recognize that. And our approach to that is it a drug we're giving? Is it IBD? Is it an autoimmune gut disease? Or is it IBS? I've talked about biological therapy and this whole concept of precision medicine, which is something which is on the horizon. And then a little bit about our organization, Autoimmune Alliance of South Africa. Thanks.
And thank you very much, Dr. Epstein, for your enlightening session. Now it is time to take a quick breather. We'll take a short break so you can have a stretch, grab a snack, and recharge. Make sure that you return promptly at 10:50, and we've got more valuable insights on their way.